Hello and welcome to the topic Approach to Acute Abdomen Part 2 in the Surgical Department. By the end of this topic, you should be able to define an acute abdomen, explain the pathophysiology of an acute abdomen, identify common causes of acute abdomen, identify acute abdomen from a bedside examination, and outline the investigations and management for an acute abdomen. Let's get started where we left off in Part 1. A common acute abdomen case that you may encounter could be acute cholecystitis. Acute cholecystitis is the acute inflammation of the gallbladder. The risk factor for acute cholecystitis include being females, increasing age, cholelithiasis, dysmotility of the gallbladder, ischemia, total parenteral nutrition, which causes gallbladder stasis, biliary sludge, gallstones, being diabetics who have increased risk of acute cholecystitis. As mentioned before, 90% of the cases of acute cholecystitis are due to cholelithiasis, and this is known as calculous cholecystitis, while the remaining 10% amounts to cases of acalculous cholecystitis. Acute calculous cholecystitis occur when there's an obstruction or passage of the gallstones into the cystic duct, leading to an acute inflammation and distension of the gallbladder wall. As a result of the impacted gallstones, bile will be trapped in the gallbladder, which in turn leads to irritation and increased pressure in the gallbladder. These gallstones causing trauma will stimulate the synthesis of prostaglandins, mediating the inflammatory response and resulting in secondary bacterial infection. This may then lead to necrosis and gallbladder perforation. On the contrary, the exact pathophysiology of acalculous cholecystitis still remains poorly understood but is believed to be multifactorial. Now, how do these patients present? Patients with acute cholecystitis come in with complaints of right upper quadrant pain, which is more severe and prolonged than in biliary colic, as well as postprandial abdominal pain. There may be radiation to the right scapula due to phrenic nerve irritation and known as referred pain. The patient may also come in with fever, malaise, anorexia, nausea, and vomiting. And on examination, there may be tachycardia, fever, and right upper quadrant or epigastric tenderness, often accompanied by guarding or rebound tenderness. A positive Murphy sign may be elicited, which is the sudden inspiratory pause upon deep palpation of the right upper quadrant due to pain. In terms of investigations and management, we can look at in terms of laboratory investigations as well as radiological studies. As for lab investigations, a full blood count, a C-reactive protein, liver function tests, and serum lipase or amylase, as well as blood or bile culture can be done. And in terms of imaging studies, we generally perform a transabdominal ultrasound as well as a CT scan if we are suspecting complicated cholecystitis. An MRI is not usually performed, however, it's done when there's complication suspected or the previous scans are equivocal. In terms of a full blood count, typically we are looking for leukocytosis, and bear in mind that in some patients the white cells may be normal. C-reactive protein will be elevated. The LFTs may show mild elevations of ALP, ALT, or GGT, as well as bilirubins. Additionally, a mild elevation of amylase may be seen in acute cholecystitis, but the elevation of 3 or more times from the upper limit might suggest acute biliary pancreatitis instead. And in terms of imaging modality, a right upper quadrant transabdominal ultrasound is the choice. Characteristic findings include thickened gallbladder wall, distended gallbladder, a double wall sign where the inner and the outermost layer appear hyperechoic due to edema. As for a CT scan and an MRI, this would reveal findings such as irregular thickening of the gallbladder wall, an interrupted rim sign due to poor contrast enhancement of the gallbladder wall. When it comes to management, initial management includes identifying any sepsis, assessing the fluid status, and resuscitating with intravenous fluids as appropriate. Next would be analgesics and antibiotics if infection is suspected. Definitive management includes a laparoscopic cholecystectomy, And the gold standard treatment for acute calculus cholecystitis is a laparoscopic cholecystectomy, which should be performed as soon as possible unless operative and anesthetic risk outweigh the benefits of urgency of the surgery. In patients where operative risk outweigh the benefits of the surgery, there are temporary measures that can be carried out. Examples would be a percutaneous cholecystotomy, where a catheter is placed into the gallbladder under image guidance, and local anesthesia via the abdominal wall to provide biliary draining, and endoscopic gallbladder stenting, which may be preferred over percutaneous cholecystotomy if skilled operator is present, as it is less invasive. In terms of prognosis and complications, if the prognosis of uncomplicated acute cholecystitis is excellent with low mortality. However, a significant portion will either need surgery or develop complications. These include gangrenous cholecystitis, gallbladder perforation, cholecystoenteric fistula, suppurative cholecystitis, subhepatic abscess, and chronic cholecystitis. Now let's take a look at the next condition under acute abdomen, which is acute pancreatitis. This is the inflammation of the pancreas. This is a disorder of the exocrine pancreas, particularly associated with acinar cell injury with local and systemic inflammatory response. The risk factors include chronic alcoholism, malignancy, hyperlipidemia, or hypercalcemia, to name a few. In terms of etiology of pancreatitis can be remembered by the mnemonic get mashed. G for gallstones, E for ethanol or alcohol, T for tumors, could be pancreatic tumors, ampullary tumors, or cholelococcal. M for microbiological, such as bacterial, viral, or parasitical infections. A autoimmune, like SLE. S for surgery or trauma. H for hyperlipidemia, hypercalcemia, and hypothermia. E for emboli or ischemia, and D for drugs or toxins such as azathioprine, furosemide, or it could be idiopathic. For clinical features, the main symptoms of acute pancreatitis is mid-epigastric or upper left quadrant pain that radiates to the back. The pain is described as severe, constant, and dull. Aggravating factors include being supine and after meals, whereas relieving factors include leaning forward. The patient may also present with nausea or vomiting, fever, and if pulmonary complications are present, they will also have chest pain or dyspnea. General examinations may reveal signs of shock, such as tachycardia or hypotension, oliguria or anuria, might also be jaundice present. On abdominal examination, will be abdominal tenderness, distension or guarding, ileus with reduced bowel sounds, and tympany on percussion. Very rarely, skin changes such as positive Cullen sign, Gray Turner sign, and Fox sign is seen. Cullen sign is the periumbilical ecchymosis and bluish-red discoloration, whereas the Gray Turner sign is the flank ecchymosis with discoloration, and a Fox sign is ecchymosis over the inguinal ligament. In terms of investigations and management, the severity of pancreatitis at 48 hours after remission is predicted with the use of the Glasgow-Imrie criteria. Again, the mnemonic pancreas can be used to remember the different parameters. A score of 2 plus indicates a moderate severity, with a score 3 plus indicating a severe severity. As for lab investigations, we can order a full blood count, renal profile, liver function test, a random blood sugar, lactate dehydrogenase levels, as well as electrolytes. The values may suggest acute pancreatitis as seen in the Glasgow-Imrie criteria. Radiological investigation-wise, an ultrasound abdomen is the first-line imaging modality as it is much easily available. Supportive findings include features of acute pancreatitis such as peripancreatic fluid and/or ascites and an enlarged hyperechoic pancreas. There may also be features of biliary pancreatitis, present such as cholelithiasis and or a gallbladder sludge and dilated biliary tree. You can also consider doing a CT abdomen where you may see features of acute pancreatitis such as peripancreatic free fluid, indistinct pancreatic margins with surrounding fat standing. Sometimes you may see edema or even evidence of complications such as necrotizing pancreatitis. Lastly, you can consider ordering an endoscopic retrograde cholangiopancreatography, or also known as ERCP, when you suspect choledocholitis or to evaluate for sphincter of OD dysfunction. Initial managements include ABCDEs and acute stabilization, hemodynamic and respiratory support, and maintaining nil per mouth. Furthermore, alleviate pain by providing analgesics such as NSAIDs or opioids. If appropriate, stop the progression of the damage and treat any local or systemic complications. Surgical therapy can be done depending on the etiology, and in acute gallstone pancreatitis, you can carry out cholecystectomy or sphincterotomy. While in recurrent pancreatitis with sphincter dysfunction, a major papilla sphincterotomy may be considered. In terms of prognosis and complications, the mortality rate in those without organ failure is less than 1%, but increases to about more than 30% when there is organ failure. Remember that patients with biliary pancreatitis have a higher mortality rate than those who have alcohol-induced pancreatitis. Complications of acute pancreatitis include pseudocyst, which is a cyst-like structure encapsulated with fibrous material, collection of pancreatic juice outside the normal boundary of the ductal system. Splenic vein thrombosis, pericardial effusion, shock, and pericarditis. And other complications include fluid collection, abscess, necrosis, fluid accumulation in the pleural space leading to pneumonia, ARDS and atelectasis, as well as acute renal failure due to the direct extension of inflammation to the kidneys. Let's summarize. Acute cholecystitis is the inflammation of the gallbladder. Patients typically present with the right upper quadrant pain with a positive Murphy sign. Investigations that can be sent include a full blood count, CRP, a liver function test, serum lipase, amylase, blood or bile culture. A right upper quadrant transabdominal ultrasound is the imaging modality of choice, and the gold standard treatment would be laparoscopic cholecystectomy for acute calculous cholecystitis. On the other hand, in acute pancreatitis, that is an inflammation of the exocrine pancreas with associated acinar cell injury. Cardinal signs include mid-epigastric or left upper quadrant pain. Patients may also come in with jaundice or shock. A Glasgow-Imrie criteria is used to predict the severity of pancreatitis. Lab investigations include a full blood count, renal profile, liver function tests, random blood sugar, LDH and electrolytes, while ultrasound abdomen is the first line imaging that's done. A CT scan can be done to look at complications of pancreatitis. Management focuses on supportive and corrective measures for any underlying pathologies. We have come to the end of this topic. Thank you for your time.